Elective cardioversion restores normal heart rhythm, sinus rhythm, from atrial fibrillation using electrical shocks or medications. Electrical cardioversion is performed under sedation for comfort and safety. The shock is painful otherwise. Preparation is required for this, and the regular echocardiogram you have had will help assess fitness for anesthesia. As with all sedation or anesthesia, full fasting of 6 hours for solids and 1 to 2 hours for water. An IV cannula will be inserted to administer sedation or any other drugs required. Supplemental oxygen will be given via nasal cannulae or prongs in your nose. Propofol is the commonest sedative, which may be given with a pump to keep you asleep for both procedures, although with sedation some vague memory is possible, but quite unusual. Elective cardioversion is recommended for symptomatic, persistent or new-onset atrial fibrillation, where rhythm control is necessary to improve symptoms or function. Success rates for electrical cardioversion are 70 to 90%, while medication-based methods may achieve 50 to 70%. Shorter AF history improves outcomes significantly. Long-term atrial fibrillation management, antiarrhythmic drugs, anticoagulation, or catheter ablation to reduce recurrence and prevent complications like stroke. Uncommon risks of cardioversion include stroke, arrhythmias, skin burns, and sedation side effects. Proper preparation minimizes these risks. This includes assessment for anesthesia, a questionnaire and review of tests, plus talking to you before the procedure. Cardioversion is quite a safe procedure and worth the small risks, unless you are extremely unhealthy. Though even then, a return to normal rhythm should improve your cardiac function. Defibrillation pads are placed ideally front and back for maximum success rate. Shaving may be required. Atrial fibrillation lasting over 48 hours increases stroke risk due to clots forming in the heart, especially the left atrial appendage. Patients need anticoagulation for 3 weeks and/or a trans-esophageal echocardiogram (TEE) or TOE outside the USA to check for any clots before cardioversion. TEE uses an ultrasound probe through the mouth into the esophagus to visualize the heart more clearly and from behind for better views. It can detect clots in the left atrial appendage, which may cause a stroke if dislodged. If no clots are found during TEE, cardioversion can proceed immediately and safely, even in urgent situations. If clots are detected, cardioversion is delayed, and anticoagulation therapy is continued or changed, or prescribed if not already, to dissolve the clot before proceeding. Later repeat TEE and shock if no clots. If no clots, then the defibrillator is set, oxygen turned off briefly, and everyone stands clear for safety. A shock, for example 200 joules biphasic, is delivered, and the trace examined for return to normal sinus rhythm. Sinus rhythm with 1 shock is ideal, but if not, then up to 3 shocks can be tried, usually increasing energy up to 360 joules. If still not cardioverted, then the procedure has failed. Anticoagulation is continued for at least 4 weeks after cardioversion to prevent new clots as the heart stabilizes. Consider joining anonamed.com to improve emergency safety if you have any serious condition, take blood thinners and so on.